everyone. First of all, I'd like to thank Dr. Luciana Macedo for inviting me today to talk about systematic reviews and meta-analysis. My name is Lisandra Almeida, and before you get started, allow me to start just by saying a few words about my own background. I'm a physio by training, and I'm currently a second-year PhD student in the School of Rehabilitation Science at McMaster, and I work under the supervision of Dr. Macedo. I love reading and conducting systematic reviews, and I hope you'll find out why by the end of this presentation. In this talk today, I would like to concentrate on a few topics, as you can see on the screen. Firstly, I'll explain what is a systematic review, and then I will describe and compare two different types of reviews, the narrative review and the systematic review. Meta-analysis is a subset of systematic review, and both systematic review and meta-analysis will be the main focus of today's talk. Soon after that, I will give you some reasons for why researchers do systematic review, and then I will explain step by step how we should read a systematic review. I will also explain the grade approach, what this is and why and how we use it. And finally, I will conclude my presentation by talking about clinical practice guidelines. So systematic reviews sit on top of the evidence-based medicine pyramid because they represent the strongest form of evidence that you can have. Therefore, learning what a systematic review is and how we should read a systematic review will be really helpful for you as a clinician, a researcher, or an academic, for example. So what is a systematic review? Basically, a systematic review is a study of studies. In other words, the information taken from each one of the individual studies is combined into one review. So why should we want to do or read a systematic review? Firstly, because in complex topics, there may be many published papers about the topic that you might not have time to read them all and make a conclusion by yourselves. Secondly, because we may want to increase the precision of estimates, as each one of the individual studies may have a smaller sample size, so individually, they don't have a good precision, right? In other words, its confidence intervals are huge and you want to increase that. So by taking a bunch of them, you can put them all together and get a bigger pooled sample size and increase the precision. The third reason is because perhaps there is a lot of discrepancies in the literature. So maybe we have some studies in favor of a particular intervention and other studies against it. So through a systematic review, we may have a summary of all the studies and may take a look at the all them up together and come up with a conclusion. Now I will talk about the main features, applications, and limitations of two types of reviews, the narrative review and the systematic review. The first type is a narrative review. The main feature of this study design is that narrative reviews focus on describing published studies only. The content found in a narrative review is usually used for general debates or for a brief review only. Narrative reviews have some main limitations that you need to address. The first limitation is that the assumptions and planning for conducting a narrative review are unknown. So if you are reading a narrative review, we don't really know whether and how the authors planned the assumptions, what criteria they have used for including or excluding eligible studies, for example. And because of all these aspects, narrative reviews cannot be reproducible. Being reproducible is a good thing in research because it means that the methods used were clearly described. And narrative reviews often summarize the reviewed studies in series, like Jones found this, Brown found that, Smith found something else altogether, rather than integrating information across the studies. The second type is a systematic review. Unlike the narrative review, the systematic review has the methods very well defined. So the review question, eligibility criteria should be predefined and clearly described. The methods of data extraction and data analysis should also be explicit on the methods section. And in terms of applications, systematic reviews are used to identify, assess, and synthesize on a specific topic, collect what is known about this topic, and comprehensively report the process, assumptions, and methods used. Therefore, well-conducted systematic reviews are reproducible. One limitation of this study design is that the scope is limited by the defined query, search strategy, and also the eligibility criteria. But to be honest, I don't think this is a truly limitation though. And meta-analysis, as I said before, is a subset of systematic reviews. We need to conduct a systematic review to be able to conduct a meta-analysis. In this case, when we are able to conduct a meta-analysis, we take the data from each individual studies, then pull them all together and then evaluate that. So systematic reviews with meta-analysis provide a more accurate estimates of treatment effect. One of the most important applications for systematic reviews with meta-analysis is guiding evidence-based practice decision-making. However, when the included studies are not homogeneous, meta-analysis cannot be performed. And again, the focus of today's talk will be on systematic reviews with meta-analysis. Now let's consider you are a clinician and you usually see a lot of individuals with low back pain. And before the COVID-19 pandemic, you used to offer them a face-to-face evidence-based intervention. However, after the pandemic, your clients or your patients have been asking you for a digital health intervention option so they can continue to receive an evidence-based treatment. But you are not sure whether you should offer them a digital health intervention or a minimal intervention only, such as a booklet, for example. So before accepting to deliver a digital health intervention, you decided to look for evidence to support your decision. So you're going to use the PICO elements to formulate a research question, okay? So you decided to look for papers testing the effectiveness of digital health interventions for low back pain individuals when compared to minimal interventions such as a booklet on pain, disability, and function. So now you decided to search for studies on PubMed, for example. And however, by doing a simple search, you found 120 studies, including RCTs, observational studies, and other study designs on this topic. As you have seen during the last 2 weeks, the best study design to test the effectiveness of an intervention is a randomized controlled trial, right? So you decided to focus your search on RCTs only. By using a filter, you found almost 30 RCTs on the topic, but this is still too much to read them all and make a decision, right? So suddenly you thought about looking for systematic reviews with meta-analysis only. And after using the meta-analysis filter, you could find 5 systematic reviews, which becomes much more feasible to read, right? As you have the results from individual studies all combined in one systematic reviews, you decided to read the systematic review. But before that, we have to learn how to read one systematic review. And as I am one of the authors of these systematic reviews that is showing on the screen, I'm very familiar with its methods, its strengths, and also limitations. So I decided to use this review to show you step by step how to read one review. So this systematic review was published in the Spine Journal in 2017, almost 5 years ago. And this was one of the first systematic reviews on this topic. After the publication of this review, a bunch of RCTs have been published, and we'll see what impact these new papers may or may not have on our decision-making process. And the most important section of the systematic review, or even of a scientific paper, is the methods, right? And based on what we have seen on the methods, we can decide whether we can trust on the results or not. So for this reason, and also for the sake of time, I will jump to the methods section. So one of the first steps you should take while reading a systematic review is identifying whether the review's objective or research question is the same as ours. So in this case, the review's objective matches with ours because they have the same intervention. So they are testing the effectiveness of telehealth based interventions for the same population, which is people with low back pain, and they are measuring the same outcomes that we are interested in. So pain, disability, and function. Something is missing here, that is the comparative interventions, but maybe the authors have described this information and the eligibility criteria. So let's look at this further later on. So this is the first paragraph under the material and method sections of this review. And this paragraph has two essential information. The first one is the PRISMA recommendations. The PRISMA stands for Transparent Reporting of Systematic Reviews and Meta-Analysis. And PRISMA is an evidence-based minimal set of items for reporting in systematic reviews and meta-analysis. And this is the PRISMA checklist, and it's basically a 27-item checklist to guide a transparent reporting of the information. So using PRISMA is not mandatory, but this is definitely a good practice, and most journals have been requiring to use it before publication. So as you can see here on the screen, there are items related to each section. So regarding the title, the abstract, in terms of introductions, a lot of items related to methods. And we also have some items from the results and also the discussion section. The second important information is regarding the Prospero. Prospero is an international database of prospectively registered systematic reviews, and every systematic review must have a predefined protocol. The protocol will briefly describe how the review is planned to be conducted. And this registration should be done prospectively. In other words, before starting the review itself. So it will help to avoid unplanned duplication and to enable comparison of reported review methods with what was planned in the protocol. And this number here is the registration, the Prospero registration number of the rehabilitation review. The third aspect we should look at while reading a systematic review is the inclusion and exclusion criteria. As we are reading the systematic review to base our practice, we need to make sure the eligibility criteria match our patients and our reality. So for this review, They included only adults with no specific low back pain, studies evaluating any type of telerehabilitation intervention in isolation or in combination with other interventions. And here they reported the comparative intervention, which could be a control group, including no intervention, a waiting list, minimal intervention, or even usual care. And they measured pain, intensity, disability, function, and quality of life. And they have included only RCTs. And in terms of the exclusion criteria, they excluded studies with participants with history of spinal surgery, and also participants with history of serious spinal pathology, such as cancer, fracture, or other systemic disease. And this means that if most of your patients have undergone spinal surgery recently, or if they had a spinal fracture, or if they have cancer, this systematic review is not the best for you, right? Because this systematic review excluded this population. But let's consider this is not your case, so your patients met the review's inclusion criteria. So let's move on to the next step. So after making sure your client or your patient and your situation are similar to the review's inclusion criteria, we have to check whether the review's authors have conducted a comprehensive search. So I know this is a subjective topic, but the recommendation is conducting a search on at least these three databases: Medline, Cochrane Library, as known as Central, and Embase. But if the topic of your interest has a specific database, it should also be added into this list as well. And to avoid missing ineligible papers, it's also recommended to do a hand searching on reference lists of previous systematic reviews on this topic, and also on reference lists of included studies. And additionally, authors usually contact experts in the field to ask if they have any ongoing study that will come up and be published very soon. So reading systematic reviews, we expect to see that authors used at least two of these three strategies. And now looking at how the authors of the systematic reviews on telerehabilitation conducted their search, we can see here that in addition to the three recommended databases that is highlighted in pink, authors also used other three databases, which is highlighted here in yellow. And they also reported that they did a citation tracking in the reference list of included studies and other important publications, which is highlighted in green. And I think the authors did a pretty good job in using the strategies to find eligible studies, and what means that it's very unlikely that any eligible studies was not captured by this search. And as you can see here on the bottom of the screen, the authors have also attached their search strategy. Remember the reproducible thing we talked about earlier today? By giving the search strategy and also all the database that I have used, this review, these methods of this review becomes reproducible. So it's good. Another important information that is that you need to double check is whether the authors have applied any restriction to the search. So in this case, they have reported no restrictions on language or country of publication, which is fine. But let's imagine you were reading a systematic review on a culture and authors have applied a language restriction only studies written in English was included. There may be some studies that were published in China in their language that will not be included in the review, right? So this hypothetical culture review may present an important selection bias. So when you are reading a systematic review, always try to make sure the search conducted by the authors was comprehensive enough according to your context. So after conducting the search in each databases and also performing the other strategies to try to capture all the potential eligible studies, authors combine then all together all the results of each database and each strategy and combine them all together and then start the screening process. If you ever do a systematic review, I highly recommend using the Confidence software for screening process because it's really helpful. But typically, the screening will be a two-step process. So firstly, they identify the studies from the search will be reviewed by title and abstract for relevancy. Subsequently, the reviewers should review the full text to ensure that studies meet the inclusion criteria. And after that, authors will extract the data from those included studies. And to enhance the reproducibility of both the screening and data extraction process, these three stages must be performed by at least 2 independent reviewers. And when disagreements between these 2 reviewers happen, a third reviewer should be asked to help to make a final decision. In the rehabilitation review, we reported that both the study selection as well as the data extraction process were performed by 2 independent investigators, as you can see in the screen highlighted in green. The next step is looking at how the methodological quality of included studies was assessed and how this is in overall. So we have different risk of bias tools according to each study design, as you have seen in the previous lecture. And for example, if the systematic review included only RCTs, authors probably use the Pedro risk of bias or the Cochrane risk of bias tool. If for any reason they have also included quasi-experimental studies, they may have used the Robbins tool or even the National Institutes of Health Quality Assessment tool. And other option is that there are also reviews focused on patient-reported outcome measures. And in this case, the COSME is the best assessment tool. And the risk of bias assessment will also be helpful to get a quality of evidence through the GRADE approach. We'll talk more about the GRADE approach in a while. And again, this process, the risk of bias assessment, should also be performed by 2 reviewers. And if any disagreement happened between these 2, a third reviewer should be required to help and make a final decision. So in a review, we use the Pedro scale, and again, the risk of bias was performed by 2 independent investigators. And up to this point, everything we have seen so far is similar in systematic reviews with or without meta-analysis. And the only difference between them will be regarding the data synthesis and the data analysis. So in terms of data analysis, let's imagine we have a bunch of fruits here, as you can see on the screen. We have apples, oranges, and also bananas, right? What the authors of systematic reviews do for analyzing their data is organizing their data according to their similarities. For example, the apples will stay all together here, same for orange and also for bananas. But I don't know if you noticed, but there is a different type of apple here. And as this is not similar to the green apples over there, we cannot put this apple in the same group as the other ones. And after you have organized the groups here, we analyze the data of each group. But now let's see how the authors of the third rehabilitation review organize the data. So basically, they organize the data according to the outcomes. So in terms of pain intensity or disability. They also organized according to the time point follow-up, or either short-term or medium-term. And also according to the low back pain chronicity. For the meta-analysis, we had only studies evaluating the effectiveness of rehabilitation for chronic low back pain. So from now on, I will show only results from chronic low back pain individuals, okay? So basically, in meta-analysis, the results of each of the studies are converted to confidence intervals, allowing all of the studies to be evaluated against a common indicator of no difference. These results are shown as a forest plot. And I know this might have become confusing now, but I'll try to clarify a little bit. So this is how a forest plot looks like. Basically, what a forest plot does is take all the relevant studies asking the same questions, identifies a common statistics inside papers, and display them on a single set of axes. Doing this allows you to compare directly what the studies show and the quality of that results all in one place. But before we talk about the results, I will try to explain what each piece of this graphic means. So the vertical line is known as the line of no effect. This line is placed as the value where, as the title suggests, there is no difference between two interventions. And as we are talking about mean difference, as you can see here, the value of this vertical line will be 0. The horizontal line represents the outcome measures in a scale for the statistics being displayed. And as you can see here on the left side, the left-hand side is in favor of the rehabilitation interventions, while the right-hand side is in favor of minimal interventions. And on the left column here, we can see that the list of individual studies included in this meta-analysis. In this case, we have 4 studies. On the second column here, we have the mean and the 95% confidence intervals for each individual studies included in the systematic review. And this information is also displayed graphically here on this graph. So both mean and 95% confidence intervals are information collected from the individual studies, okay? And as you might know, the 95% confidence interval is a range of values that you can be 95% confident that contains the true mean of the population. For example, for the Chayes study, we have a mean of -4, which is represented here by this square, and a lower limit confidence interval of minus 9.5 and an upper limit of 1.6. One very important information is when the 95 confidence interval crosses the line of null effect, the vertical line, this means that there is no difference between the two interventions. So in this case, all the confidence intervals for each study crossed the vertical line. So by concluding, this final row here is like a conclusion of the comparison. So in this case, there is no difference between a telerehabilitation intervention and a minimal intervention on pain at short term for chronic low back pain patients. And this diamond here and the meta-analysis considered the means and 95% confidence intervals from each individual study, as I said before. And this final row here gives all the relevant information, and all the studies are brought together into a single figure. This diamond here shows us what is the final results. And again, if the diamond crosses the vertical line, we can conclude that there is no difference between telerehabilitation and minimal interventions on pain intensity at short term for chronic low back pain patients. We found the same results in terms of disability at short and also at medium-term follow-ups, which means that there is no difference between telerehabilitation and minimal interventions on disability at short and medium-term follow-ups for chronic low back pain patients. So in case you need to take a bio break, this is the best time for doing so. So please take a 5 or 10 minutes break and then come back for us to talk more about the GRADE approach and the quality of evidence found by the systematic review, and then quickly talk about clinical practice guidelines. Welcome back, everyone. So now we'll be talking about the next step for the systematic review, which is the quality of evidence. The GRADE approach was developed by a team from McMaster University, and it allows researchers conducting systematic reviews to summarize the quality of the evidence available. And the GRADE reflects on how confident you should be about the fact estimates identified on the review. So there are 4 grades of level of evidence, from high quality to very low quality of evidence, or you may also have no evidence available. And the higher the quality of evidence is, the more confident we are on the results, and the addition of new studies into the review are unlikely to provide different outcomes. So the high evidence level, for example, means that further research is very unlikely to change the confidence in the estimates of effect. On the other hand, the very low level of evidence means that an estimate of effect is very uncertain. So this is the conclusion of the telerehabilitation review. And in terms of the quality of evidence, the authors said that there is moderate quality of evidence that telerehabilitation is not superior to minimal interventions for reducing pain and in chronic low back pain patients at short and medium term follow-up. So this means that there is moderate quality of evidence that there is no difference between both interventions. But what moderate quality of evidence means? It means that further research is likely to have an important impact in the confidence in the estimates of effect. Remember that I said before that after the publication of these reviews, a lot of RCTs have been published on this topic. So these new studies are essential because they may change the confidence, the results, and also the confidence in the estimate of effect. But if this systematic review had found high quality of evidence for most outcomes and comparisons, no more studies would be needed because new studies will probably not change the confidence in the estimate of effect. In other words, the new studies would not change the results in terms of effectiveness. So, but let's try to understand how the grid approach is used and how we should evaluate the quality of evidence. So this is a screenshot from the GRADE website. And we can see here that the information that I need to upload to generate the quality of evidence. So in this first column here, on the left side, hand side, we need to specify the outcome and the total number of participants and the number of studies included in each comparison and time point, for example. So as you can see here, this would be an example for the comparison between rehabilitation and minimal interventions, okay? For pain intensity at short and intermediate terms follow-up. So for pain intensity at short term, we included over 400 participants, 441 within 4 RCTs. And for pain intensity at intermediate term, we included 634 participants within 5 RCTs. The next information is on the difference. As you can see here on the yellow column. So we need to report the mean and the 95% confidence interval from each comparison. And this information comes from the final row from the forest plot that we talked before, that summarize everything on each comparison of the forest plot. So these results are from an updated systematic review on rehabilitation for low back pain that I'm just updating. And I don't know if you notice, but now we have different results. So we do have a difference in terms of effectiveness between telerehabilitation and minimum interventions. And I would say here that at this point, the addition of the new RCTs actually change the results. And now telerehabilitations are more effective than minimal interventions. So there are 5 factors usually taken in consideration when assessing grade, and they are used to downgrade the quality of evidence. So the 5 factors are risk of bias, inconsistency, indirectness, imprecision, and publication bias, as you can see on the right-hand side. On the next slide, I will describe each one of these factors. But before that, I'd like to try to show you how the website asks us to choose how to downgrade the level of evidence. For example, for the risk of bias assessment, if you find reasons for downgrade the level of evidence in terms of risk of bias by 1 level, we will come to the serious risk of bias. So we start with no serious, and then we come, you downgrade the level for serious risk of bias. But if you find reasons for downgrading the level of evidence by 2 levels, we will click here at the very serious risk of bias. The same will happen with inconsistency, indirectness, imprecision. The only difference in terms of publication bias, that we have only 2 options. Publication bias is undetected or detected. Okay, so the first factor that will downgrade the level of the quality of evidence is the risk of bias. And risk of bias can be assessed using a validated tool. And for RCTs, for example, authors can either use Cochrane risk of bias tool or the Pedro scale, for example. And there are other tools available for different study designs, as you mentioned before. And according to the risk of bias evaluation, studies are classified into two categories, either low risk of bias or high risk of bias. And based on that, if more than 25% of participants in the comparison are from studies at high risk of bias, we would downgrade the level of evidence by one level. But if more, at least 50% of our participants are from studies at high risk of bias, we will downgrade the level of evidence by 2 levels. The second factor is inconsistency. Inconsistency means that there is heterogeneity in results across studies. So we need to look at the point estimates and the confidence intervals for each included studies, as well as the statistical test of heterogeneity. On the first plot here on the slide, as you can see, although all studies cross the null line, the vertical line, some studies trended towards favoring the experimental group, the left-hand side, while others trended towards the control group, the right-hand side. And it's clear that there is some inconsistency among included studies. Additionally, the I-square value here on the bottom of the screen that is highlighted in blue shows a 96% of heterogeneity, demonstrating a high statistical heterogeneity. So in terms of inconsistency, authors can downgrade the level of evidence by one level when they found important and non-explained heterogeneity, or when the I-square is greater than 50%. On the other hand, when they find evidence of serious inconsistency, or when the I-square is greater than 75%, they downgrade the level of evidence by 2 levels. The third factor is indirectness. Indirectness is related to how the included studies in the systematic review differ from the PICO elements outlined on the review research question. Yeah, this also evaluates the external validity of the study. So in terms of evaluation, if more than 50% of participants are outside the target population, we will downgrade the level of evidence by one level. And if more than 75% of participants are outside the target population, we will downgrade the level of evidence by 2 levels. The fourth aspect is imprecision. And imprecision relates to the imprecision of the effect estimates on wide confidence intervals. When evaluating continuous outcomes, imprecision is evaluated by looking at the length of the confidence intervals, whether it includes null values and potentially clinically significant results. It's also downgraded by the total number of patients in each comparison. When evaluating the economos outcomes, it's really evaluated looking at the number of studies as well as the number of events within the comparison, and also whether confidence intervals include null and clinically significant results. So as you can see here, we will downgrade the level of evidence by one level when we have a small sample size, and in this case would be 300 events for the economos outcomes and 400 patients or participants for continuous outcomes, or when the confidence intervals include null values, or when they cross the line, the vertical line, right? And when happen one situation or the other, we will downgrade the level of evidence by one level. But when we have both situations, both small sample size and the confidence intervals include new values, we would downgrade the level of evidence by two levels. And the last factor is publication bias. Publication bias relates to the probability that identifying effect estimates are overestimated due to the likelihood that the studies that identified no effects are not being published. Publication bias is assessed using funnel plots, but however, funnel plots can only be constructed for comparisons with at least 10 studies. So funnel plots are scatter plots of the effect estimate on the horizontal line or the horizontal axis and study precision on the vertical axis. So no publication bias is presented by an inverted funnel, as you can see here on the left-hand side on the graphic, the letter A. But publication bias is often represented by a lack of studies in either bottom of the funnel plot, as you can see here, highlighted by this red circle. And it's missing some studies on the left-hand side of the figure number, the figure B. So we will downgrade the publication bias factor when the study report is not matching with the pre-published protocol, or even when the forest plot shows asymmetry. So here we can see the final table from the new systematic review on rehabilitation for low back pain. And based on what we have seen so far, we can conclude that there is very low to low quality evidence that there is a small effect after rehabilitation, which is 2.2 and 6.5 out of 100 when compared to minimal interventions on pain at short and at intermediate term follow-ups. And we found similar results on disability at short and intermediate term follow-ups. So we can also conclude that there is very low to low quality evidence that there is a small effect of rehabilitation compared to minimal interventions on disability at short and medium term follow-ups. So after reading the systematic review, we need to finally think how to apply the results into local practice, right? Again, think if the included participants match with your patients, your clients, your reality. Make sure you get the quality of evidence related to each outcome of interest and also regarding each time point. And you also need to think about the costs and also the benefits of applying the results into your practice, because maybe there is a high quality evidence in favor of an intervention, but your patient cannot afford it. So in this case, you and your patient, your clients, need to discuss other evidence-based options. And to finalize my presentation, I will quickly go over clinical practice guidelines. So reading scientific papers may be a little confusing and also time consuming sometimes, mainly for healthcare providers. And that's why clinical practice guidelines exist. So clinical practice guidelines are systematically developed statements to assist practitioners and patient decisions about appropriate healthcare for specific circumstances. In other words, clinical practice guidelines are standardized evidence-based recommendations used by healthcare providers to make informed decisions about patients' care. So these guidelines will help us as a healthcare providers better understand, recommend, and deliver the best healthcare for each patient situation. So one example of clinical practice guidelines is the NICE low back pain guideline. As you can see here in this visual summary, When a patient with low back pain comes to see us, according to the NICE guideline, we need to screen the patient and exclude the possibility of having serious spinal pathologies, such as cancer, fracture, or infection, for example. And if you think the patient has one of these conditions, we must refer the patient to a specializing health professional. So if your patient has no specific low back pain, and we then need to assess the prognosis of your patient by using, for example, a start back risk assessment tool, as you can see here. And after that, we can classify the patient in one of these three categories here: good, likely outcomes, or poor prognosis. And according to this category, we can choose, you can get a sense of what intervention would be the best for your patient. For example, if your patient has a good prognosis, we can just deliver a group exercise. On the other hand, if the patient has a poor prognosis, we may need to deliver or recommend a physical and a psychological intervention program, for example. But what I want you to learn from this simple example here is that clinical practice guidelines are usually developed by researchers to help clinicians and other healthcare providers get the best evidence and apply the best evidence into the practice. So finally, I'd like to remember that evidence-based care is a triad of three domains: the best scientific evidence, patients' values and preferences, and our clinical experience and preferences as well. So the best evidence-based care that you can offer to your patient, your client, needs to be based on these three main domains. So this is a list of reference. If you feel we need more information or how to conduct a systematic review or even how to read a systematic review, I highly recommend you to access the Cochrane Handbook for Systematic Reviews of Interventions. Is the best resources you can get. And also I included two others others resources regarding the GRADE and also one regarding the PRISMA. So thank you for watching my presentation until the end. And I hope this has helped you in learning how to read a systematic review and choose the best evidence-based treatment options for your patients. If you have any questions, feel free to send me an email and I will be happy to answer you. Bye-bye.